Welcome back to the deep dive. I am so glad you're joining us today.
Yeah, it's great to be here. We have a really packed session.
We do. We're exploring a truly fascinating landscape today, using chapter 2.5 from the Oxford textbook of global public health as our structural spine.
Right.
And as we step into this material, whether you've read the chapter yet or not, I want you to keep a very specific metaphor in mind.
The crystal ball metaphor.
Exactly. We often hear genomics talked about in the media as if it is a crystal ball. A magical glowing sphere that just definitively predicts a person's or a population's ultimate destiny.
Which is, it's just completely inaccurate.
Completely. As we're going to explore today, genomics isn't a crystal ball at all. Rather, it's a highly detailed, high-resolution map of our biological terrain.
And a map is incredibly valuable.
Oh, for sure. But a map is really only useful if you actually know how to navigate the social, environmental, and structural roads that ultimately determine where populations end up.
That is an excellent way to frame our mission for this deep dive. We are exploring the exact intersection of molecular insight and population benefit.
Right.
Our goal today isn't just to, memorize a sequence of DNA bases or list off the symptoms of rare diseases.
We're not doing a biology pop quiz here.
No, definitely not. We are here to build clear conceptual frameworks. We want to understand exactly how a genomic risk translates into an environmental exposure, how that interaction leads to health outcomes, and ultimately, how we use that knowledge to design system-wide public health interventions.
We're looking at the entire pathway.
From a tiny string of nucleotides all the way to a massive shift in public policy.
And to you, our listener, whether you're a medical student furiously prepping for your board exams, a public health trainee mapping out future health policy, a practicing clinician,
Or honestly, just someone who recently spit into a tube for a consumer DNA test.
yeah, and you're sitting there wondering what those results actually mean for your future, this deep dive is custom tailored for you.
We want to arm you with the mental frameworks you need to think critically about genomic medicine.
Rather than just blindly accepting the technological hype. Okay, let's unpack this.
Let's do it.
We have to start by looking back. Because to understand where public health genomics is going and why it operates the way it does, we have to understand the massive historical divide that kept genetics and public health completely isolated from one another for decades.
It is a critical starting point. We have to face the history honestly.
Right.
Historically, there was a profound ethical and philosophical chasm between these two fields. And we can't discuss this without acknowledging the legacy of the eugenics movement.
Right, going back to the late 19th century.
Yeah, the term itself, eugenics, was coined by Francis Galton back in 1883. It translates roughly to well-born.
Which sounds innocuous, but the reality was anything but.
Exactly. The central philosophy, which we now know is deeply, fundamentally flawed, was that the human gene pool could somehow be improved by selective breeding and the control of reproduction.
It was a dark era.
It led to horrific human rights abuses, forced and involuntary sterilizations across Europe and the U.S., and it was ultimately invoked to justify the atrocities committed during the Holocaust.
And beyond the obvious moral repugnance of those actions, there was a fundamental scientific failure at the core of eugenics, too.
A total misunderstanding of biology.
Right. It operated on this assumption of absolute biological determinism. Eugenics falsely assumed that human traits, intelligence, behavior, criminality, health, were solely dictated by genetics.
It completely ignored what sociologists refer to as the habitus.
The environment.
Yeah, it ignored the social environments, the embedded power structures, the poverty, the structural realities that interact with human agency. It stripped away all context and just blamed the biology.
Which is why the science was as terrible as the ethics. Because of this understandable revulsion against eugenics, throughout the mid to late 20th century, mainstream public health just distanced itself completely from the study of genetics.
Public health doubled down on what it knew worked.
Sanitation, clean water.
Population-level interventions, environmental regulations, vaccination. Meanwhile, the emerging field of medical genetics retreated into a highly individualized clinical space.
Very one-on-one.
Extremely. Genetics became intensely focused on individual autonomy, non-directive counseling, informed consent, and privacy.
Which created a specific culture, right?
Yeah, what we sometimes call genetic exceptionalism. The idea that genetic data is uniquely sacred, inherently more sensitive, and entirely separate from other routine medical data.
So you have these two massive pillars of human health operating in total
Societal silos.
silos. Public health wouldn't touch genetics, and genetics was entirely focused on the individual, not the population. But a bridge was eventually built between them.
Very specific practical bridge.
Right, a way these two fields finally had to start communicating again. And that bridge was constructed in the 1960s with the advent of newborn screening, specifically screening for a metabolic disorder called phenylketonuria, or PKU.
PKU is arguably the foundational case study for public health genomics.
Walk us through the mechanism.
Sure. PKU is a rare inherited metabolic disease. It's caused by a genetic deficiency in an enzyme called phenylalanine hydroxylase.
And normally, what does that do?
Under normal circumstances, your body uses this enzyme to break down an amino acid called phenylalanine, which is found in almost all the protein we eat.
So if a baby is born with PKU,
They lack this enzyme. So as soon as they start consuming breast milk or standard infant formula, phenylalanine begins to rapidly build up in their blood and their tissues.
it becomes toxic.
Highly toxic. If left untreated, this buildup causes severe, irreversible neurological damage and profound intellectual disability shortly after birth.
It's a devastating natural history, but here's the mechanism that brought public health to the table. If you detect this deficiency immediately after birth, you can intervene.
You can change the outcome completely.
You put the infant on a strict, specially formulated phenylalanine-free diet. And if you maintain that dietary intervention, the infant can achieve completely normal cognitive development.
The phenotype is altered.
Exactly. The phenotype, the severe brain damage, is entirely prevented, even though the underlying genotype remains exactly the same.
What's fascinating here is how this perfectly illustrates the synergy of gene and environment. The genetic mutation is harmless unless it encounters the environmental exposure.
Which in this case is dietary phenylalanine.
Right. But from a policy perspective, PKU screening revolutionized how we thought about genetics. We weren't just diagnosing a tragedy anymore.
They were intercepting it.
We're intercepting it.
Which introduces such an essential conceptual framework for our listeners, especially if you're in clinical practice. Screening isn't just about finding out what's wrong for the sake of curiosity.
No, never.
Screening is only justifiable when an effective, acceptable intervention exists. We didn't mandate heel-prick blood tests for every newborn in the country just to give parents a terrifying diagnosis.
We screened because we had a literal recipe to prevent the morbidity.
That is the absolute core of public health intervention, and this concept was formalized in 1968 by two researchers, Wilson and Jungner.
Commissioned by the World Health Organization.
Yeah, the Wilson and Jungner criteria remain the gold standard for evaluating any population screening program.
They demand that the natural history of the disorder must be adequately understood. The screening test itself must be reliable, valid, and acceptable to the public.
And crucially, as you just highlighted, there must be an accepted, effective, and available treatment or preventive intervention.
You do not screen populations for diseases you cannot treat.
I want to contrast that historical clarity with what we are seeing today, because the landscape has shifted dramatically.
It really has.
We currently have incredible technological enthusiasm in the biotech sector. We can sequence so much so quickly. In the United States, for example, the Secretary's Advisory Committee on Heritable Disorders in Newborns and Children recommends screening for up to 31 core disorders, plus another 26 secondary ones.
That's a massive panel.
It is, but there is a very real debate happening right now. Are we bypassing those vital Wilson and Jungner guardrails?
We are definitely testing the boundaries of those guardrails.
How so?
The friction arises because the technological capability to detect a variant has vastly outpaced our clinical ability to do anything about it. We are sometimes screening for conditions where the clinical intervention isn't totally clear.
Or where the disease might not manifest until adulthood?
Right. In some cases, the argument is that we should screen just to end the diagnostic odyssey for parents.
Just to give them an answer.
Yeah, or to give them reproductive information for future pregnancies. And while those are valid clinical desires, they don't necessarily fit the strict public health mandate of preventing immediate disease through direct intervention.
Which blurs a really important line. If we want to build our conceptual frameworks today, we must clearly differentiate between two things: clinical diagnosis and population screening.
This is a vital distinction.
Take it down for us.
Clinical diagnosis is what happens when a patient is already sick. They are sitting in your clinic, exhibiting symptoms, and you're running tests to figure out what is wrong with them to guide their treatment.
And population screening.
Completely different. You are applying a test to an asymptomatic, seemingly healthy population. Often people who haven't even asked to be tested.
Just to intercept disease early.
Exactly. Because you're dealing with healthy people, the ethical bar for population screening must be immensely higher.
Because of the risks involved.
You're introducing the risk of false positives, the psychological harm of unnecessary anxiety, and the physical harm of potential overtreatment.
Right. If I walk into a clinic with chest pain, the threshold for running a test is low because I already have a problem. But if the government decides to test every healthy person in the country for a genetic heart defect, the burden of proof that this will actually help more people than it harms is astronomical.
It's a completely different risk-benefit calculus.
Okay, let's move our timeline forward. We've bridged the gap with newborn screening. Let's talk about the monumental paradigm-shifting event in this field, the Human Genome Project.
A massive undertaking.
This ran from roughly 1990 to 2003, and the goal was to sequence the entire 3 billion DNA base pairs that make up a human being. This project catalyzed a massive shift in how we categorize the science itself.
Moving from traditional medical genetics to what we now call genomic medicine.
To understand that shift, we need to define the terms. What was medical genetics?
Medical genetics traditionally dealt with rare, highly penetrant, single-gene disorders.
The Mendelian diseases.
Right, following the laws of inheritance described by Gregor Mendel. Think of cystic fibrosis, Duchenne muscular dystrophy, or Huntington's disease.
In these conditions, a mutation in a single specific gene has a massive biological effect.
If you inherit this specific mutation, you have a very high likelihood of developing the disease. The relationship between the genotype and the phenotype is strong and direct.
But genomic medicine is something entirely different. Genomic medicine is the attempt to understand common complex diseases.
The things that actually fill up hospital wards.
Type 2 diabetes, coronary artery disease, asthma, schizophrenia. These are not caused by a single broken gene. They are driven by polygenic risk.
Polygenic meaning the combined cumulative effect of hundreds or even thousands of different genetic variants spread across the entire genome, all interacting together.
And investigating polygenic risk required a completely new way of doing science.
The Human Genome Project essentially created what we now call infrastructure science.
Meaning what, practically?
Before this, genetics was often driven by a single principal investigator in a lab, hunting for years to find one specific disease-causing gene in one specific family lineage.
Very isolated research.
But to understand complex diseases, you need massive scale. So we saw the rise of enormous, publicly funded international consortia, projects like the HapMap Project, the 1000 Genomes Project, and ENCODE.
We weren't hunting for a cure immediately.
No, they were building the foundational maps of human genetic variation. They were cataloging exactly where human genomes differ from one another across different populations.
And once we had those massive maps, it allowed for the invention of a new statistical tool, the Genome-Wide Association Study, or GWAS.
The famous GWAS.
Now, for anyone who isn't a genomic researcher, a GWAS is essentially a massive scanning operation. You take the genomes of 100,000 people with type 2 diabetes and 100,000 people without it.
And you scan millions of tiny genetic markers.
Called single nucleotide polymorphisms, or SNPs, across all their genomes, and you look for statistical associations. You ask the computer, are any of these SNPs significantly more common in the people with diabetes?
It was a revolutionary approach. When GWAS first came onto the scene, there was an immense amount of hubris.
People thought it was at the finish line.
The expectation was that we were finally going to find the diabetes gene or the heart attack gene, and that these discoveries would immediately yield new drugs and perfect predictive tests.
But the results of those early, massive studies were profoundly humbling.
Incredibly humbling. We had built the map, but we realized we didn't fully understand the language it was written in.
The GWAS data revealed something called the missing heritability problem. We knew from family histories that diseases like type 2 diabetes were highly heritable.
But the individual genetic variants that GWAS identified only offered incredibly tiny increases in risk.
We are talking about odds ratios of maybe 1.1 to 1.5.
To put that in perspective, if you carry a common risk allele, a specific SNP associated with type 2 diabetes, your risk of developing the disease might be 1.1 times higher than the general population.
A 10% relative increase.
Right. But if the baseline risk in the population is only 5%, your personal risk is now 5.5%.
It's a statistically significant finding for a researcher, but it is practically meaningless for a clinician trying to advise a patient sitting in front of them.
It takes hundreds of these tiny variants acting together to even begin to meaningfully predict disease.
This realization fundamentally shifted the scientific philosophy. It took that age-old, exhausting debate of nature versus nurture and finally put it to rest.
It's not nature versus nurture.
It is a highly synergistic model of nature and denurture. The genes alone rarely dictate the outcome for common diseases. It's the genetic susceptibility interacting dynamically with environmental exposures over a lifetime.
If we connect this to the bigger picture of public health, this was a moment of immense vindication.
How so?
Well, there was a fear that sequencing the genome would make traditional public health obsolete, that we would just fix everything at the molecular level.
Right.
But the GWA's data proved the exact opposite. Because polygenic risk is so diffuse and the odds ratios are so small, it proved that the environment is the primary driver of disease manifestation.
You might have a genetic susceptibility to obesity.
But if you live in a built environment that encourages walking and have access to affordable, nutritious food, that genetic risk may never manifest into clinical disease.
Okay, so if the DNA sequence itself, the actual A, C, T, and G letters, isn't changing over our lifetime, how exactly does the environment interact with it? What is the actual biological bridge between the stress of poverty or a poor diet and the expression of our genes?
That bridge is an exploding field of biology called epigenetics.
Epigenetics.
Literally translated, epigenetics means above genetics. It refers to biological mechanisms that change how a gene is expressed, meaning whether the gene is turned on or off without actually altering the underlying DNA sequence.
Think of the genome like the hardware of a computer, and the epigenome is the software telling the hardware what to run.
A perfect analogy. A classic example of an epigenetic mechanism is DNA methylation.
Walk us through methylation.
This is where small chemical tags called methyl groups physically attach to the DNA molecule, usually as cytosine bases. When a region of DNA is heavily methylated, it tightly coils up, making it impossible for the cellular machinery to read the gene.
The gene is effectively silenced.
Silence. And what's crucial is that environmental signals directly influence this methylation process. Chronic stress, exposure to environmental toxins, nutritional deficits in utero, all of these can trigger epigenetic changes that alter gene expression for decades.
And sometimes those epigenetic tags can even be passed down to the next generation.
Yes, transgenerational epigenetic inheritance.
So public health didn't become obsolete with the genome sequence. Its role was just chemically validated. We now have the molecular proof that structural public health interventions, cleaning the air, reducing chronic stress, ensuring childhood nutrition, are actually altering the biological software of the population.
It's incredible validation.
Let's dig deeper into the actual mechanics and the pitfalls of using this genomic data for risk assessment, because the statistics here are where many people, even highly trained clinicians, get tripped up.
It's easy to misinterpret.
Why is it so inherently difficult to use genotypic information, like finding a few SNPs on a consumer DNA test for the primary prevention of common diseases?
It all comes down to the math of predictive values, and specifically the positive predictive value, or PPV.
The PPV asks a very simple, vital clinical question.
If my patient tests positive for this genetic variant, what is the actual probability that they will go on to develop the disease?
And for common, complex diseases, the PTV of these genetic tests is usually abysmal. But why? If the test is perfectly accurate at finding the gene, why is the PPV so low?
Because of a concept called penetrance.
Penetrance.
Penetrance is the likelihood that a person who carries a genetic variant will actually manifest the observable trait or disease.
With Mendelian disorders like Huntington's, the penetrance is near 100%. If you have the gene, you get the disease.
But for the risk alleles identified by GWAs for common diseases, the penetrance is incredibly low. Because those odds ratios are only 1.1 or 1.2, the vast majority of people walking around with a risk variant will never develop the disease.
Right.
So if you test a healthy population for a variant with low penetrance, the vast majority of your positive results will be people who are never going to get sick. Your PPV plummets.
I want to make sure this lands. If a test tells you that you have a common risk allele for a heart condition and the doctor says you tested positive, your immediate human reaction is panic.
Of course it is.
But the statistical reality is that you likely won't get the disease anyway because the variant relies on 100 other factors to actually cause harm.
And conversely, there's a huge danger on the other side.
The false negative feeling.
Right. If you test negative for that specific variant, you might falsely feel completely immune.
False reassurance is a massive public health danger. A negative genetic test for a complex disease does not mean you have zero risk. It just means you don't have that one specific variant out of the thousands that exist.
You could still develop coronary artery disease through entirely different genetic or environmental pathways.
Beyond the math, there are also incredible biological complexities that make editing out diseases nearly impossible. We have to talk about pleiotropy.
Pleiotropy is fascinating.
It's a phenomenon where a single genetic variant influences multiple, completely seemingly unrelated physical traits. You can't just pull on one genetic thread without unraveling something else.
The classic example that Oxford highlights is the APOE4 variant.
APO4 is a brilliant illustration of this biological trade-off.
The APOE gene codes for a protein called apolipoprotein E, which is involved in metabolizing fats in the body. Now, if you carry the APOE4 variant, epidemiological studies show it significantly increases your risk for developing late-onset Alzheimer's dementia.
And it also increases your risk for coronary heart disease.
It looks like a purely bad gene.
So the immediate sci-fi thought is, let's use CRISPR to edit out APOE4 from the human gene pool.
But here's the catch. Carrying that exact same APOE4 variant simultaneously decreases your risk for developing age-related macular degeneration, which is a leading cause of blindness.
Wow.
It also appears to offer protective immune advantages against certain infectious diseases early in life, which is likely why it survived evolutionary selection in the first place.
Biology is full of these evolutionary trade-offs. You cannot simply imagine a future where we broadly fix or edit out a risk gene without understanding the massive, system-wide, unintended impacts.
We also see the danger of premature population screening when we look at a gene called HFE.
Let's talk about HFE.
This gene is associated with hereditary hemochromatosis, which is a condition where the body absorbs too much iron from the diet.
Over decades, this iron builds up in the organs,
Particularly the liver, potentially leading to cirrhosis or liver cancer. A while back, there was a massive push to screen the entire population based on the HFE genotype.
The logic seems sound. Find the people with the gene and prevent liver damage through a very simple, low-tech intervention.
Therapeutic phlebotomy, or regular bloodletting. But the public health gatekeepers stepped in and halted the push.
And rightfully so, because they looked at the penetrance data. It's true that if you have the predisposing HFE genotype, you have a higher risk.
Roughly 25 to 50% of people with those genes will show biochemical evidence of iron overload on a blood test.
However, the actual penetrance of the severe clinical outcome, the overt liver disease we actually care about preventing, is incredibly low.
Some studies suggest it might be as low as 1 to 10% of people with the genotype.
So think about the system-wide impact of that. If you screen the entire population, you are going to flag millions of people.
You are going to create immense psychological anxiety.
Require decades of unnecessary follow-up blood tests, and put a massive financial burden on the healthcare system for a severe disease that 90 to 99% of those flagged individuals would never, ever develop.
It violates the core principles of public health utility.
This brings us to a really interesting psychological area, the behavioral paradoxes of genomic testing. How do humans actually react when you hand them a piece of paper detailing their genetic risk?
The assumption has always been that knowledge is power.
That if you tell someone they are at high genetic risk for diabetes, they will immediately join a gym and change their diet.
But human behavior is never that simple. It's the classic human trap.
If a test says I have a low genetic risk for a metabolic disorder, my brain immediately translates that to, great, my genes are invincible, I can eat donuts for breakfast every day.
Which obviously defeats the whole purpose and dramatically increases your environmental risk.
And the research bears this out. While knowing you have a highly penetrant condition like familial hypercholesterolemia might increase your adherence to statin medication, for common complex diseases, genetic risk information doesn't reliably change long-term behavior.
Sometimes it induces fatalism. People think, well, it's in my genes, there's nothing I can do, so they give up trying to eat healthy.
Or, as we mentioned, people with a strong family history of a disease might test negative for one specific variant and perceive their overall risk as artificially low.
Leading to false reassurance.
Which brings us to a foundational public health concept that every listener needs to internalize. Jeffrey Rose's prevention paradox.
Rose was an epidemiologist who fundamentally changed how we think about preventing disease.
He argued that if you want to reduce the overall burden of a disease in a society, A small, sweeping reduction in risk across the entire population achieves a far greater impact than perfectly targeting the small group of individuals at the highest genetic risk.
Let's map that out mathematically. Imagine a population of 1 million people. Only 1% of them have a high-risk genetic variant for heart disease.
Okay, 10,000 people.
If you spend millions of dollars finding those 10,000 people and give them personalized, intense clinical interventions, you might prevent a few thousand heart attacks.
But the vast majority of heart attacks in your city are actually happening in the other 99% of people who just have average genetic risk but poor diets and sedentary lifestyles.
Exactly. So Rose's paradox says, forget the expensive genetic dragnet.
If you implement a population-wide policy like a structural reduction in dietary sodium across all processed foods or redesigning city infrastructure to promote active, walkable transport, you lower the blood pressure of all 1 million people by just a tiny fraction.
But that tiny shift across a massive population will prevent exponentially more heart attacks than the highly targeted, high-tech genetic approach.
It highlights why public health focuses on the environment. However, this doesn't mean we ignore genetics entirely. There is an ultimate, beautifully low-tech genomic tool that seamlessly integrates all of these concepts.
And every clinician already uses it.
Family history.
Family history. It is arguably the most powerful genomic tool we have, and it doesn't require a sequencer.
Think about what a family history actually represents. It inherently captures shared genetics, yes. But it also beautifully captures shared environmental exposures, shared cultural diets, and shared learned behaviors over generations.
It aggregates the entire gene-environment interaction into one simple conversation.
From a public health perspective, family history acts as a highly effective, low-cost triage tool. Instead of sequencing everyone, you use family history to stratify a population into average, moderate, and high-risk groups.
If your family history puts you at average risk, you get standard population-level public health advice. Eat well, exercise.
If you are at moderate risk, maybe you get more frequent cholesterol checks or personalized lifestyle interventions.
Only the group identified as high risk, say multiple first-degree relatives with early-onset cancers, gets referred to a specialist for expensive clinical genetic testing.
It's an elegant, systemic use of genomic principles that manages resources efficiently.
It respects the immense complexity of disease etiology while remaining grounded in practical clinical utility.
Here's where it gets really interesting, though. When we do decide to run the sequencers, when we move from public health policy into the actual clinic, how are these high-tech tools being deployed right now?
We need to clearly differentiate the types of clinical genetic tests because they serve vastly different purposes.
Let's do that. First, let's look at diagnostic tests.
Diagnostic tests are deployed when a patient is already symptomatic. You're trying to confirm a clinical suspicion.
Give us an example.
For example, an infant presents to a pediatrician with delayed motor milestones and muscle weakness. The clinician suspects Duchenne muscular dystrophy. They order a genetic test, specifically looking for mutations in the dystrophin gene.
The test isn't predicting the future.
It is confirming the present reality to guide immediate medical management.
Then we step into predictive tests, which are trickier. Predictive tests are split into two distinct camps, pre-symptomatic and susceptibility.
This is a crucial distinction. Pre-symptomatic testing is used for highly penetrant, usually Mendelian conditions where the outcome is near certain.
The classic paradigm is Huntington's disease.
Right, an autosomal dominant neurodegenerative disorder caused by excessive CAG repeats in the DNA. If you undergo pre-symptomatic testing for Huntington's and you have the mutation and you live long enough, you will almost 100% develop the disease.
The test is a virtual guarantee of future illness.
Susceptibility testing, however, is very different. This is for conditions where a mutation indicates a significantly elevated risk, but not an absolute guarantee.
Testing for mutations in the BRCA1 and BRCA2 genes, which are tumor suppressor genes, falls here.
A woman with a BRCA1 mutation has a much higher susceptibility to developing breast and ovarian cancer compared to the general population.
But it is not 100%. She might never develop cancer. It's predictive, but it's a probability, not a certainty.
And because it's a probability, it requires intense genetic counseling so the patient understands exactly what the risk means before they make drastic decisions, like prophylactic surgery.
And then there's pharmacogenetics, which is just incredibly cool. This is the study of how our specific genetic makeup affects our metabolism of and response to pharmaceutical drugs.
This is the promise of truly personalized medicine.
The classic, highly instructive example here is the anticoagulant drug warfarin.
Warfarin dosing is famously difficult in clinical practice. It has a narrow therapeutic index, meaning the difference between an effective dose that prevents blood clots and a toxic dose that causes severe bleeding is very small.
Clinicians constantly have to monitor the patient's blood clotting time, their INR.
But we now know that a patient's response to warfarin is heavily governed by two specific genes.
Let's break those down. First is the CYP2C9 gene.
Yeah.
This gene produces an enzyme in the liver that breaks down warfarin. This dictates the drug's pharmacokinetics.
Meaning how the body handles the drug.
Right. If you have a genetic variant that makes you a poor metabolizer, the drug builds up in your system, and a standard dose could cause fatal hemorrhage.
The second gene is VKORC1. This gene dictates the drug's pharmacodynamics.
Meaning how the drug physically interacts with its molecular target in the body.
VKORC1 produces the enzyme that warfarin actually inhibits to stop clotting. Certain variants make this enzyme more or less sensitive to the drug.
So knowing a patient's variants in both CYP2C9 and VKRC1 allows a clinician to mathematically predict a much more accurate starting dose of warfarin.
It is brilliant, but even here we have to acknowledge the limitations.
Because it's not the whole story.
Not at all. Even with perfect genetic knowledge of CYP2C9 and VKORC1, a patient's response to warfarin is still heavily affected by their age, their biological sex, their body mass index, their dietary intake of vitamin K, like how much spinach they eat, and interactions with other medications.
The genetic test is a powerful adjunct, but it absolutely does not replace careful clinical evaluation and standard blood monitoring.
Finally, we need to clarify the difference between somatic and germline testing, especially in the context of oncology.
This is a vital differentiation. Think of your germline DNA as the original master blueprint of a house handed down from your parents. Every single room in the house, every cell in your body contains a copy of this blueprint.
If there is an error in the germline, it is everywhere, and you can pass it on to your children.
Somatic mutations, however, are like someone deciding to spontaneously knock down a wall in just one specific room of the house decades after it was built.
It is a localized mutation that occurs in a specific tissue, usually leading to a tumor. It is not inherited, and you cannot pass it to your kids.
In modern oncology, we frequently use somatic testing to profile the specific genetics of a tumor to guide targeted therapy.
For example, testing a breast cancer biopsy for the overexpression of the HER2 gene. If the tumor cells, the somatic cells, have this mutation, we know the patient will likely respond well to a targeted monoclonal antibody called Herceptin.
That distinction is so important for clinicians because somatic testing usually only impacts the immediate treatment of the patient sitting in front of you.
But germline testing, finding an inherited mutation, has immense ethical, emotional, and medical implications for the patient's siblings, their parents, and their children.
So with all these different types of tests rapidly flooding the commercial market, how do public health officials actually evaluate them? How do health ministries or insurance companies decide what gets funded and used and what gets tossed in the bin?
This is where an indispensable evaluation tool called the ACCE framework comes in.
The ACCE framework.
It is the absolute bedrock for evaluating the appropriateness of genetic tests. It was developed by the CDC, and it forces a rigorous, multi-layered assessment.
ACCE stands for Analytic Validity, Clinical Validity, Clinical Utility, and ELSI, Ethical, Legal, and Social Implications. Let's walk through them carefully because this is how public health thinks.
Let's start with the first hurdle, analytic validity. This is fundamentally a question for the laboratory. Can the assay reliably and accurately detect the specific genetic variant it claims to detect?
Basically, is the machine working properly?
If I send the same blood sample to the lab 10 times, do I get the exact same sequence result 10 times?
Analytic validity is necessary, but it is entirely insufficient on its own. A test can perfectly identify a mutation, but we still need to know if that mutation matters.
That brings us to clinical validity. Does finding this specific genetic variant actually predict the presence or future onset of the clinical disease in the real world?
This is where we bring back our epidemiological metrics.
Yeah.
Sensitivity, specificity, and positive predictive value.
If a biotech company invents a test that is analytically flawless at finding variant X, but epidemiological studies show that variant X is only found in 2% of people with the disease, its clinical validity is incredibly poor.
It doesn't actually help you find the sick people.
And then we reach the third tier, which is the absolute most important metric for public health decision-making: clinical utility.
Clinical utility asks the brutal "so what" question. It asks, does performing this test actually change the clinical management of the patient in a way that improves their health outcome?
This is where so many tests fail.
Wait, so even if a test is perfectly accurate and correctly predicts the disease, it can still be considered useless.
In a public health sense, absolutely. If a test accurately tells a patient that they will inevitably develop a neurodegenerative disease in 20 years, but there is absolutely no treatment, no preventative measure, and no way to alter the course of the disease, the clinical utility is extremely low.
You haven't changed the outcome. You have just introduced decades of psychological burden.
The Oxford chapter gives a great clinical example of evaluating utility, testing for the factor V Leiden variant.
This is a genetic variant that increases the risk of blood clots. Say you have a patient who has already suffered a deep vein thrombosis, a DVT. Should you run a genetic test to see if they have factor V Leiden?
Under the ACCE framework, we look at the evidence. Studies show that knowing the patient has the factor V Leiden mutation doesn't significantly change their risk of having a recurrence compared to standard clinical risk factors.
Therefore, knowing the genetic status shouldn't change how long you prescribe blood thinners.
Because the test result doesn't change the clinical management plan, the clinical utility is poor, and routine testing is usually not recommended.
And finally, the E in ACCE, ELSI, ethical, legal, and social implications. Even if a test has great utility, we must evaluate the potential for discrimination.
If we implement this test, will patients face genetic discrimination from life insurance companies? Will it cause severe stigmatization within certain communities? All four pillars must be evaluated.
To help busy clinicians actually navigate this deluge of data and complex evaluation, the CDC established the EGAP-PP initiative, the evaluation of genomic applications in practice and prevention.
They took the ACCE principles and created a very practical three-tier evidence classification system for genetic tests.
Let's break down those tiers because this is the ultimate cheat sheet for clinical practice. Tier 1 means use in practice. This is the gold standard.
The test has proven analytic validity, clinical utility, and crucially, major medical societies have published evidence-based guidelines supporting its routine use.
Newborn screening for PKU is a classic Tier 1. Testing for BRCA mutations in families with a strong history of breast cancer is Tier 1.
Then you have Tier 2, which means promote informed decision-making. These are tests that are analytically and clinically valid, and there's a potential for clinical utility.
Perhaps clinical trials are currently ongoing to prove it changes outcomes.
But as of right now, there are no definitive national guidelines recommending routine use. Providers can use these tests, but they must carefully counsel patients on the uncertainty.
And finally, Tier 3, which means discourage use. These are tests that lack valid evidence, lack clinical utility, or actively demonstrate a potential for harm.
Direct-to-consumer genomic panels claiming to perfectly tailor your diet to your DNA often fall here because the clinical validity and utility of those claims are virtually non-existent.
This tiered system is essential. It allows public health practitioners to act as rational gatekeepers.
They stand between eager biotechnology companies trying to sell novel tests and the safety, psychological well-being, and financial resources of patients and health systems.
Speaking of biotechnology, let's zoom out and talk about big data, infrastructure science, and an incredible emerging field called vaccinomics.
The scale of data here is just wild.
The Oxford chapter includes a staggering chart showing the plummeting cost of DNA sequencing. For decades, it followed Moore's law, the idea that computing power doubles in costs halve every 2 years.
But then next-generation sequencing arrived, and the cost dropped exponentially faster than Moore's law.
We went from the Human Genome Project, taking 13 years and $3 billion, to being able to sequence a human genome in a few days for a few $100s.
This completely inverted the bottleneck in biological science. For most of the 20th century, the bottleneck was generating the data.
Now we can generate data effortlessly. The new bottleneck is storing, processing, and actually analyzing it. We are dealing with petabytes of genomic data.
We mentioned ENCODE earlier, the Encyclopedia of DNA Elements. For a long time, there was this myth of junk DNA, the idea that the vast majority of our genome did nothing because it didn't directly code for proteins.
But in 2012, the ENCODE project announced they had mapped biochemical functions, like regulatory switches for gene expression, to over 80% of the human genome.
That discovery is the epitome of infrastructure science coexisting with discovery science. We are no longer just looking at single genes in a petri dish.
We are building massive global databases, biobanks linking electronic health records to sequenced genomes, and international data sharing networks.
This requires what the literature calls a collective intelligence that goes far beyond the capability of any single laboratory or university.
And if we connect this collective intelligence to the bigger picture, we see it directly revolutionizing fields like infectious disease through vaccinomics.
This is where the map metaphor gets really aggressive.
The chapter details this in figure 2.5.5. We are moving completely away from the historical trial and error days of Louis Pasteur, where you just weakened a whole virus and hoped for the best.
We aren't just looking at a pathogen under a microscope anymore. We are digitally mapping a pathogen's complete genomic architecture.
We are identifying its secretome, cataloging all the individual proteins the pathogen secretes into the host.
And we are mapping its surfome, the exact molecular structure of every protein expressed on its surface.
If you think of a virus like a microscopic submarine, the surfome is mapping every single antenna, hatch, and periscope on the exterior.
And simultaneously, we are mapping the human immune response, a field called immunomics, and analyzing the vast genetic variation in how different human immune systems respond to threats.
By integrating all of these massive data sets, scientists can engage in reverse vaccinology. They can sit at a computer, look at the precise 3D structure of the pathogen's surface proteins, and rationally design a highly precise synthetic molecule that perfectly trains the immune system to target that exact vulnerability.
It is systems-level engineering.
And what's truly remarkable is that this concept extends far beyond communicable infections. The principles of vaccinomics are being applied to non-communicable diseases, specifically oncology.
The text highlights susceptibility, which is an FDA-approved therapeutic vaccine for castration-resistant prostate cancer.
It's absolutely mind-blowing. We can essentially use the genomic architecture of a patient's own rogue cancer cells to train their immune system to hunt down and attack the tumor.
It is a phenomenal achievement. But as public health practitioners, we must maintain our structural perspective.
Right, zooming back out.
For highly complex, big data fields like vaccinomics to actually reduce global disease burden, the entire trajectory from data generation in a lab to bioinformatic analysis to clinical trial innovation to mass manufacturing to equitable global distribution must be seamlessly connected.
It must be socially contextualized. A brilliant synthetic vaccine on a computer server saves 0 lives.
This brings us to another brilliant conceptual framework. How is genomics supercharging traditional, old-school epidemiology?
It's doing it through a technique called Mendelian randomization.
This might be one of the most elegant conceptual frameworks in modern public health research. To understand its power, we have to look at the flaw it fixes in traditional epidemiology, the massive problem of confounders.
In epidemiology, it is notoriously difficult to definitively prove causality based on observation alone.
Let's use the classic example. Say researchers observe that populations with a very low intake of dietary folate have significantly higher rates of babies born with neural tube defects, like spina bifida. The association is strong.
But as an epidemiologist, you have to ask, is it actually the lack of folate biologically causing the defect? Or is it a confounder?
Do people with low folate diets also tend to have lower incomes, higher levels of chronic stress, poor overall nutrition, or live in areas with higher environmental toxins?
Any one of those socioeconomic confounders could be the actual cause of the birth defects. The lines are hopelessly blurred.
The only way to definitively prove causality is a randomized controlled trial, where you randomly assign some pregnant women to get folate and others to get a placebo.
But ethically, you obviously cannot do that if you suspect the placebo group will suffer severe birth defects.
Enter Mendelian randomization. It is essentially nature's own randomized controlled trial.
Because genes are randomly assorted at the exact moment of conception, thanks to Gregor Mendel's law of independent assortment, your genetic makeup is completely immune to typical epidemiological confounders.
Your genes don't change based on your adult income, your zip code, or your lifestyle choices later in life. You get what you get at conception.
Right. So epidemiologists look for a genetic variant that biologically mimics the environmental exposure they wanted to study. In this case, they used a common polymorphism in the MTHFR gene, specifically the C677T variant.
Let's track the mechanism here. If you inherit this specific MTHFR variant, it slightly reduces the activity of a specific enzyme in your body.
This reduction causes an artificial rise in homocysteine levels in your blood, which effectively mimics the exact biological effects of having a low dietary folate intake.
So epidemiologists looked at massive population data sets. They separated people based purely on their random genetics. Those with the MTHFR variant mimicking low folate, and those without it.
Because this variant was randomly assigned at birth, the two groups have essentially identical socioeconomic status, identical stress levels, and identical access to care on average.
All the confounders cancel out.
And what did they find? They found that the group with this random genetic variant who have biologically mimicked low folate their whole lives had significantly higher rates of neural tube defects.
Because the gene was randomly assigned, it cuts through all the noise. It proved, beyond a shadow of a doubt, the causal biological link between folate deficiency and neural tube defects.
It is a beautiful piece of science. It provided the hard, indisputable evidence needed to justify a massive structural public health intervention. Government mandates to fortify bread and grain products with folic acid.
This single intervention has prevented thousands of severe birth defects globally. It is a perfect example of using genomic variation not to treat individuals in a clinic, but to uncover universal biological truths that inform population-wide policies.
The same logic of observing natural genetic variation applies to studying host pathogen coevolution. It's an evolutionary arms race happening in our DNA.
A prime example of this is the CCR5 receptor polymorphism. In the 1990s, researchers noticed that certain individuals, despite repeated exposures, seemed highly resistant to HIV infection.
By studying the genomes of these individuals, they discovered a specific genetic deletion called CCR5 delta 32.
HIV typically uses the CCR5 receptor on the surface of human T cells as a doorway to enter and infect the cell. But people with this genetic mutation have a physically altered receptor.
The doorway is essentially locked, and the virus cannot enter. This discovery didn't just explain a biological mystery, it gave the pharmaceutical industry a direct genomic blueprint.
If nature could lock the doorway with a mutation, scientists could design antiretroviral drugs, CCR5 antagonists, to artificially block that same receptor in everyone else.
It even led to the famous Berlin patient, the first person functionally cured of HIV, after receiving a bone marrow transplant from a donor who naturally carried that exact CCR5 mutation.
It is the ultimate translation of evolutionary genomics into clinical therapeutics.
This raises a massive pressing question, though. We are talking about billion-dollar infrastructure science, massive sequencing consortia, and designer immunotherapies. How do we ensure these incredible high-tech advances translate to low-resource settings and the developing world?
Global ethics and equity must be at the very forefront of public health genomics. Otherwise, we are just engineering wider health disparities.
Equity is the central challenge. The Oxford text heavily critiques that concept we mentioned earlier, genetic exceptionalism.
If we treat genetic data as uniquely terrifying and insist on hiding it away in highly siloed individual vaults, we cannot do public health.
To build the global public goods needed for progress, like massive, diverse international biobanks, we have to actively balance the need for individual privacy with the need for societal solidarity and scientific altruism.
We need diverse populations to contribute their data so that the genomic maps we build are actually representative of the whole human race, not just people of European descent, which has been a massive bias in early genomic research.
However, that appeal to altruism must be supported by vigorous, unyielding ethical oversight. The chapter cites a vital study by DeVries regarding genomic research in Africa.
It highlights a critical, unique risk in genomics: group harm. If a massive biobank analysis uncovers a high prevalence of a certain disease-causing variant in a specific, identifiable ethnic or regional group, what happens to that information?
Without strict governance, that entire ethnic group could face intense social stigmatization, discrimination from employers, or targeted exploitation. The ethics cannot just protect the individual, they must protect the community.
And when we look at actually applying genomic medicine in the developing world, it's not always about exporting million-dollar CRISPR therapies or advanced pharmacogenetics.
It's about using robust, low-cost genomic tools for the rapid diagnostics of local infectious diseases such as tuberculosis or malaria.
It's about using genomics for bioremediation engineering microbes to clean up heavy metal contamination or environmental degradation in highly polluted areas.
It is also about managing the extremely heavy genetic disease burdens that already exist, specifically the hemoglobinopathies like sickle cell disease and thalassemia.
These are the most prevalent monogenic disorders in the developing world. The chapter notes that roughly 7% of the global population are carriers for a hemoglobin disorder.
And this goes back to our evolutionary arms race. Why is the sickle cell trait so common in certain parts of the world? Because carrying one copy of the gene, being a heterozygote, confers a natural protective advantage against severe malaria.
The genome adapted to the environment. But carrying two copies results in devastating sickle cell disease.
Managing these disorders in low-resource settings is where systems thinking is absolutely paramount. Genomics is useless in a vacuum.
A cheap, accurate genomic test to screen newborns for sickle cell disease in a rural, low-resource setting is a technological triumph.
But it is an utterly useless and potentially cruel public health intervention if there isn't an established, functioning healthcare system in place to subsequently provide those infants with prophylactic penicillin to prevent lethal infections and safe, clean blood transfusions when they experience crises.
That is the perfect encapsulation of our entire deep dive. Genomics expands the public health toolkit in miraculous ways, but it absolutely does not replace the foundational historical commitments to equity, prevention, and basic infrastructure.
You still need clean water, you still need sanitation, and you still need functioning rural clinics. The most advanced DNA sequencer in the world cannot replace a working sewer system or a reliable supply chain for basic antibiotics.
Exactly. As we conclude this chapter's analysis, the resounding message is that we must avoid a narrow, technocentric lens. Integrating genomics into global health requires deep local expertise, transparent and ethical policy environments, and a relentless commitment to addressing the actual practical disease burden of the population, rather than simply chasing the most technologically flashy interventions.
Okay, we have covered a massive amount of conceptual ground today, from the history of eugenics to the mathematics of polygenic risk. It is time for our learning reinforcement segment. I am going to ask you, the listener, to actively test your recall and your clinical reasoning. My colleague will read the single best answer prompts.
We will pause deliberately after each question to give you a moment to lock in your answer. Think through the mechanism, and then we will break down the reasoning together. Here we go. Question 1. Which criteria are most critical when a public health body is evaluating the addition of a newly discoverable genetic condition to a state-mandated newborn screening panel? Take a second to think.
The answer is the Wilson and Youngner criteria, and most specifically, the availability of an acceptable, effective, and accessible intervention. Remember, the PKU story, the diet, is what makes the screening ethical. If you want to review this mechanism, revisit the newborn screening section under Genomics and Improving Health in your chapter.
Question 2. A researcher finds a statistically significant association between a novel genetic variant and the onset of type 2 diabetes, with an odds ratio of 1.2. However, this genetic test is never ordered in routine clinical practice. Under the ACCE framework, which domain is this test most clearly failing? Take a moment.
The answer is clinical utility. Even if the lab test is analytically perfect, and even if it's clinically valid at identifying that tiny 1.2 risk increase, it fails because the result doesn't change the clinical management for the patient. You would just tell them to diet and exercise regardless. You can reread the evaluation of genetic and genomic tests section for a deeper look at the ACCE framework.
Question 3. What is the primary epidemiological advantage of using Mendelian randomization to study the relationship between an environmental exposure and a complex disease? Think about the mechanism.
The answer is it avoids confounding and reverse causation. Because genetic variants are randomly assigned at conception like nature's RCT, they are not influenced by adult lifestyle, income, or socioeconomic status. For a refresher on this elegant concept, look back at the impact of genomics on epidemiology.
Question 4. A perfectly healthy patient requests a commercial genetic panel for common complex diseases to definitively guide their long-term diet. The physician notes the test relies on polygenic risk variants with odds ratios of 1.1 to 1.5. What is the primary statistical limitation of this test for this specific patient? Lock your answer in.
The answer is an incredibly low positive predictive value, or PPV. Because the penetrance of these common alleles is so low, testing positive doesn't meaningfully predict that the patient will actually get the disease, potentially causing undue anxiety or false reassurance. This critical math is covered in the predictive value of genotypic information.
Question 5. A new predictive genetic test accurately identifies a mutation, reliably predicts disease onset, and has a proven clinical intervention. However, there are no national medical guidelines recommending its routine use yet. Under the CDC's EGPP classification system, which tier does this test occupy? Take a second.
The answer is Tier 2. This tier is for tests that promote informed decision-making because they show valid clinical potential, but lack formal, widespread guidelines for routine practice. You'll find this detailed in the evidence-based classification of recommendations section.
Question 6. In the modern context of vaccinomics and rational vaccine design, Why are serfums and secretomes targeted rather than just looking at the pathogen's naked DNA sequence? Think about the 3D structure.
The answer is because the surfum and secretome represent the actual expressed surface and secreted proteins that physically interact with the host's immune system. Understanding these physical 3D structures makes them the ideal targets for engineering synthetic immune responses. Take a look at figure 2.5.5 and the section on vaccinomics, designing the next generation of vaccines.
Excellent work today.
To close out our deep dive today, I want to leave you with a final, slightly provocative thought to mull over. We've talked entirely about human genomes and individual pathogen genomes today, but what happens when public health begins routinely, continuously sequencing the environmental genome? Imagine swabbing the subways, testing the municipal water systems, filtering the air in airports to continuously map outbreaks before a single human patient ever feels sick enough to visit a clinic. The infrastructure science we spent decades building for human DNA is about to map the invisible microbial world we breathe every single day.
Here are the details of this episode.
Genomics and Public Health, Byline, From DNA to Destiny, Translating Molecular Insight into Population Benefit. Episode description. Genomics has transformed biomedical science, but what is its place in public health, a field traditionally rooted in sanitation, vaccination, and social reform? In this chapter, we explore how genomic science intersects with population health. Advances in sequencing technologies have made it possible to identify genetic susceptibility to disease, understand pathogen evolution, and develop targeted therapies. We examine the promise and the limits of genomic integration into public health practice. While genomics enables personalized medicine and improved screening, most population-level disease burden remains shaped by social and environmental determinants. The chapter addresses key ethical and policy questions: equity of access to genomic technologies, privacy concerns, data governance, discrimination risks, and the allocation of resources between high-tech innovation and basic public health infrastructure. The chapter addresses key ethical and policy questions. We also consider the role of genomics in infectious disease control, particularly in outbreak tracking and antimicrobial resistance monitoring. The chapter addresses key ethical and policy questions. Genomics expands the toolkit of public health, but it does not replace its foundational commitments to equity, prevention, and systems thinking. The chapter addresses key ethical and policy questions. The chapter addresses key ethical and policy questions. Key takeaways. The chapter addresses key ethical and policy questions. Genomics enhances understanding of disease susceptibility and transmission. The chapter addresses key ethical and policy questions. Most common diseases result from gene-environment interaction. The chapter addresses key ethical and policy questions. Public health impact depends on equitable access to genomic technologies. The chapter addresses key ethical and policy questions. Ethical issues include privacy, discrimination, and consent. The chapter addresses key ethical and policy questions. Genomic screening must be evidence-based and proportionate. The chapter addresses key ethical and policy questions. Infectious disease genomic supports outbreak control. The chapter addresses key ethical and policy questions. Resource allocation between high technology and basic services requires balance. The chapter addresses key ethical and policy questions. Genomics complements but does not substitute structural interventions.